Someone say something real quick just so I can make sure it's coming out the right way.
Say something.
Awesome. So the way that I've got this organized is I have a brief presentation on lumbar spinal stenosis. And then after that, I would like to discuss the two papers. Does that work?
Sounds great.
Okay.
Let's do it.
Very good. So let's see, I need to share my screen here. Okay. Can you see that?
Yep.
Tell me what you see. A beach?
A beach.
All right. I took that photo. It's a pretty good photo, huh? Okay, what do you see now?
The beach.
So the beach, okay, hang on.
Pretty good photo. I like it.
I've got a PowerPoint I'm trying to share here, hang on. What do you see now?
I see the PowerPoint.
You see it? Okay, good. All right, let me see. Full screen?
Nailed it.
Okay, good. All right, so, before we talk about anything complex with spinal stenosis, it's probably good that everyone's on the same page in terms of what it is, right? And I find that despite years of training, all of us, whether we are medicine or PT or chiro or rolfers, we will have different understandings of what we think this is. So this is an important condition. And I do want to share this lecture within the context of one of my mentors named Craig Brigham. He passed away unexpectedly in April of 2013. He was a mentor of mine. He's the reason I went back to med school. Incredible human being. So this guy for the Southeast was the deformity expert. So he was the spine surgeon who dealt with the most nasty, gnarly, aggressive deformities you could possibly come across. And I recently interviewed for fellowship, and I was discussing this with the person in our system here at UPMC who's kind of the deformity guy. And he knew of Craig Brigham. And the story I told was one of a guy who had ankylosing spondylitis, and he had a 90% or 90 degree rather curve in his thoracic spine. And the reason this guy wanted surgery or consultation for surgery was not because of pain, zero pain. The reason he wanted this was because he was 74 years old and he couldn't stand up to see his wife's face. And that's the context that I want to enter this discussion, because everything we've been told about lumbar spinal stenosis is typically in the context of pain, right? And most of what we care about, we think about is pain. That's not the only reason that people want to live. It's not just about pain. Sometimes deformity matters because it affects function. And I want you to be thinking about that as we discuss this a little bit, okay? Changed my life after seeing that patient. He had the surgery, his spine was straightened, and he had not been as happy as he had been in over 3 decades, right? So that's still a matter of function, right? We just want to be able to think in terms of patients' goals. And we talk a lot about that, but sometimes we don't think about it in its full conclusion. And so that's one thing I wanted to bring up here. All right, so goals today. Define for patients what is lumbar spinal stenosis. Very important. How you and I think about this is going to be different than how patients think about this and understand it. We want to understand the natural history. We want to think in terms of the clinical history and physical exam, the pathoanatomical etiology, the workup, and the treatment. Okay. Lumbar spinal stenosis, most simply, is a decrease of space for nerves, right? Going into the legs primarily. Everybody gets radiographic stenosis. I think most of the people on this discussion can agree with that, right? And that's part of the fundamental issue that we have as clinicians, is this reality. The fact that everyone who ages is going to have a loss of space. Not everybody is symptomatic. That's the other part of this that's difficult, right? I think, unfortunately, in the far extreme interpretation of this reality, we say that structure is not related to pain. That's not the case. Structure is related to pain. It's just not always related to pain. And there are circumstances that affect what that pain means to us, right? As the experiencer. All humans shrink. It's a fact. It is based on genetic studies, Finnish twin studies. Michelle Bettier, she, out of the Pacific Northwest years ago, made her start looking at twin data, monozygotic twins. It's really crucial that we understand, if you remove all of the psychosocial elements, what happens to our biology as we age? It matters. It informs us as we try to interpret the overlay, the complex overlay that is the psychosocial experience that patients bring to the table. Okay. So as we age, we dehydrate. There's this decrease in proteoglycan content. And one thing you might want to think about as a clinician is the fact that this has a protective effect of herniation, right? So as we age, we actually decrease our likelihood of herniating, okay? So if you look at younger folks, they herniate more violently. Their herniations are aggressive, robust, problematic when they happen. As people enter middle age, as they sort of enter that sixth decade of life, the disc is very hard. It is different in terms of its content. The dehydration is important for stabilization, and there is a protective benefit to that as we age. Okay, so that's important as we discuss this as well. Some people have congenitally short pedicles. That changes the canal diameter. And this is an important fact when you think about radiological findings, okay, and diagnostic imaging. So not everyone is built the same way. Our genetics matter not just for our hair color and eye color and skin color and all those superficialities, but it matters for things as deep as the length of our pedicles, okay? We can develop acquired abnormalities. Disc degeneration does lead to increased narrowing. Facet osteoarthritis changes, or osteoarthrosis, or arthropathy. All of these things matter in terms of the structure. And again, structure is part of the equation. It's not the whole equation, but it's a big part of it we have to consider. Deformity also matters, as I mentioned initially. So if you are a patient who has an inflammatory spine condition, the extent of the deformity that you might experience is very different. A lot of folks, if they live long enough, are going to experience degenerative spondylolisthesis. Many of these folks will not need surgery, okay? Surgery is the far end of the spectrum in terms of the treatment. Some people will experience scoliosis. There's a big difference here between adolescent scoliosis and degenerative scoliosis. We will talk a little bit about that as the presentation continues. So what's the natural course of lumbar spinal stenosis? There have been many studies going back decades. This is one from 1993 that looked at 32 patients, followed them over a few years. All had myelograms. So some of these studies are hard to do today, right? Because and this is where the whole idea of saying that a study needs to be within the past 5 or 10 years is a bunch of bullshit. Because the reality is we used to do things under experimental conditions that we just have a hard time doing today. And there is valuable information in the literature that dives decades back. And so I would tell you that if you are a serious clinician, you want to be aware of the evolution of the literature, because some of the things that we determined to be valuable from 30 years ago are no longer repeated simply because they were sufficiently addressed in the past. You do not want to be ignorant of that information. You want to be aware of it. So I would challenge you to think twice about this idea that, you know, literature needs to be of a certain age. That's just not true. The nature of the literature and the work that we do, and actually what gets funded, is different today than it was decades ago. And that matters. It matters for what we can get from the information that we study. Okay. So a lot of what we know about the sort of frequency of lumbar spinal stenosis comes from more rigorous studies in the past. Okay. And that's one of the cases here. Very small canals tended not to improve, but no need for urgent surgery. So people who have congenital canal stenosis may have a increased likelihood of experiencing symptoms, but that is not the same as saying that they need surgery. And that's really an important point. And I like this slide because of that. So we're looking at natural history. This is over a decade. Surgery favored, but most people were successfully managed with non-op treatment. And look at the date of this. This is 2000, right? No downside to waiting. So the fact that we've known this for 21 years and have a difficulty implementing this in practice tells you that it's not a deficit of information or knowledge, right? How we practice is distinct from what we know to be the case. This is a really useful slide because, again, this was published in 2000. And I imagine maybe even some of you weren't even born then, right? So think about that. We hear lots of people today that we respect talking about these realities, and the fact is we've known about this stuff for decades. Nothing is new under the sun. Long-term outcomes of surgical and non-surgical management, 8 to 10-year results from a study in Maine. Over 10 years, low back pain and leg pain were similar. 23% surgery patients had another surgery. 49% of non-op had surgery. Surgery, importantly, though, in this case, was favored for low back pain and leg pain. Okay. The most favorable outcome was for surgical treatment early on. There are reasons for that. But nonetheless, most people respond really well to non-operative approaches. So the fact that we talk about surgical treatment is more about the extremes of symptoms. Okay, and that's really what these early studies were about. It was rare to have a significant neurodeficit, even decades ago, right? We knew about this. Patients with delayed surgery could achieve a good outcome still. So that's important. You know, we do talk about the fact that people have neurological deficits benefit more with early surgery, and that's true. However, if you look at large numbers of people, we see that those who have surgery later can still achieve a good outcome. And the reason for that is the nature of the problem itself. So what's the classic history? And this kind of tips into the one of the papers we're looking at with Dr. Rainville, comparison of the history and physical exam for hip OA versus lumbar spinal stenosis. So buttock or leg pain worse with standing or walking, unilateral or bilateral. And I want to point out that this particular slide was actually put together in 2011. Jim Rainville's study came out in 2019. Eric Laxer was a partner of Craig Brigham at OrthoCarolina. And so essentially, 8 years later, this concept of unilateral or bilateral symptomatology was verified by the work that Rainville did. We can talk about that a little bit. Relieved by sitting or forward flexion, grocery shop cart sign. So that was one of the things that was kind of called into question with Rainville's study, right? Good days and bad days. That's something that everyone here probably gets really well. There's not a linear course to the symptomatology that people experience with lumbar spinal stenosis. Variable low back pain. So I can tell you that I had a patient recently. I'm on the consult service now for the University of Pittsburgh Physical Medicine and Rehabilitation Service, and we had a guy who had only back pain with his spinal stenosis symptoms. However, it was worse with erect ambulation. So if he would lean forward, he would flex at his waist, his back pain would get better. He denied any leg symptoms whatsoever. He just had this sort of unusual low back pain dominant experience with his spinal stenosis. He had pretty severe stenosis, severe enough that he's being considered for inpatient rehab. So this is not just a guy who's, having some general back pain. So what do we care about in history? So if we were to go back to basics, one thing we can say about lumbar spinal stenosis is that it usually is leg dominant, okay? So the back pain dominant presentation is rare. It still can happen, however. We're trying to work out why certain people present differently, but they do present differently. And that's different than denying they present differently. And I want to emphasize that here. There's mechanical versus non-mechanical pain. When it comes to lumbar spinal stenosis, overwhelmingly it's mechanical pain. That is, you can reproduce specific positions, movements, and functions that affect it worse. Onset. If it happened yesterday, it's not lumbar spinal stenosis. Lumbar spinal stenosis is, by definition, a degenerative, evolving problem that takes years. Okay? So no one is going to be appropriately intervened on if they have a recent onset. If you're thinking lumbar spinal stenosis, this is a problem that takes years to develop. It is a age-related phenomenon. There are going to be exacerbating and relieving factors. This is where the non-operative approach excels. You as clinicians have to identify the difference between these two things, right? You want to realize what exacerbates and what relieves a patient. The reality is that, and Craig Brigham, for example, used to say this all the time. In fact, he went to battle in 2012 with Rick Dio, who some of you should be familiar with because Rick Dio is a real champion of non-operative management of spine disorders. Nonetheless, Brigham actually challenged Dio deeply on this concept of exacerbating versus relieving symptoms and the appropriateness to use that as a simple gauge for how you would treat someone with spinal stenosis. And for example, if someone has the inability to ambulate, say 200 feet, but they can get on a bike, they can row, it may be appropriate to have that person, depending on what their normal activities are, to use the rower or the bike as the means of getting exercise in their daily life. So if this is not a community ambulator, for example, they have no need to drive, they have no need to go to the store, they have a spouse or significant other who can help with this, or a family member, then it may be appropriate not to put that person in the queue for surgery, right? It's appropriate to allow them to accommodate to the sort of threshold of their symptoms. And that's something you want to be aware of. Function. All right, so what are the questions to ask? Calf pain after a precise distance, relieved by standing. So someone chime in real quick. What are you thinking if they have calf pain? What's the difference there?
Try to determine if there's like a vascular component that might be going down there as well. So like peripheral vascular disease could be something going on.
Yeah, who said that?
Ben.
I thought it was somebody I recognized. Yeah, exactly. Precisely. Can't miss those. Okay. Anyone who has peripheral vascular disease has significant vascular disease. What's the number one killer of Americans? Let's pretend that it's not 2020 COVID land. In general, 2 years ago, what was the number one killer of Americans? Cardiovascular disease, not back pain. You still can't miss the most common reasons humans die. Okay, that's why this matters. Is it painful to get out of a chair? Is a transitional movement different than climbing stairs? Is it painful to put on shoes? So that's something that the Rainville study kind of looked at as well, right? That was one of the predictors of the difference between having hip osteoarthritis and having lumbar spinal stenosis. How about recent falls? Falls adds a whole new dimension here. So if someone fell, that's very different than just having lumbar spinal stenosis. Lumbar spinal stenosis in and of itself does not make you fall. Okay, that's important. Like, sear that into your head as a spine clinician. You want to know that. What makes people fall?
Decreased sensation in the lower extremities. Could be some vestibular thing also. Could be weakness.
Yep.
Any of that.
All kinds of things that really don't relate very predictably to lumbar spinal stenosis. Okay. Do most people with lumbar spinal stenosis have proximal weakness to the point they can't stand up? No. Correct. Okay. When did they fall? How did they fall? What were the circumstances? All of that matters. If they fell immediately when they stood up, you want to be thinking about vascular issues again, orthostasis. Okay. So the deep dive here, it really matters. It will make the difference between you being an excellent clinician and being an average one. All right. Differential diagnosis: hip joint disease, vascular claudication, femoral neck stress fracture, cervical myelopathy. Cervical myelopathy is a really important one because you can have gait abnormalities because of a neck issue. And we don't want to miss that either, because that's a more ominous problem. And for younger folks, generally disc herniation needs to be included. But hip joint disease, a big one that we focused on with our study that we look at. All right, so we're moving along here. Quality of function: how far can you walk? These are common questions. What is it that causes you to stop? Huge, huge clinical pearl to add that to your patients who you think have lumbar spinal stenosis. What is it that causes you to stop? Right? Like that's a really poignant point. Add that if you're not asking that question. Okay. How long can you stand? Can you work? Okay. How long have you been out of work? How urgent? Are you seeking disability? That matters. Again, our second paper is going to tap into some of the complicated overlay. Are you able to sleep, and are you taking narcotics? All of that predicts outcome. It predicts trajectory. Narcotics, unfortunately, have a treatment blocking effect. Have any of you heard of this concept? Okay. So Jim Rainville, a mentor of mine, love this guy. Unfortunately, he's about to retire. But he was one of the first in medicine to really start talking about this concept of a treatment blocking effect, which is that people who are on narcotics chronically don't respond well to virtually anything we do to them. Okay. And there's a lot of implication to that. We're still working it out. So right now, most of the studies that have looked at this just describe it. They're descriptional studies. They say that, yeah, if you're on opioids, you don't respond well to injections. You don't even respond well to surgery. You definitely don't respond well to our psychosocial interventions like CBT and MI and all that stuff that we try. It's a problem, right? So if you think about you have a highway, okay? 95 is a big highway on the East Coast. So if you're traveling 95 and there are parts of 95 that's this like major artery for travel, it's still nonetheless, maybe 2 lanes. And you have an accident, right? Like something happens, there's a crash. The downstream effect of that is tremendous, right? Like sometimes it'll be an hour, 2-hour delay. Then you've got trucks on the highway. You've got all these kinds of demands. So the concept of opioid or narcotic treatment blocking effect is similar to that. It's kind of like it takes up so much of the real estate of the experience that a patient is having with pain that it affects everything kind of downstream. Okay. The thing that you really want to understand is that for acute pain, we're talking like if you're in the ED or you're post-op day, 12 hours, opioids are really great at blocking pain. Okay, and those studies have been done, and if you're not aware of those studies, you need to read the literature because there's a big difference between using opioids 12 hours after an injury, a catastrophic injury, and 12 days after an injury. There's a difference how the body responds. Okay, and you want to be aware of that generally speaking. But for persons who use opioids chronically, it dramatically affects their physiology in ways that are still hard for us to predict. But it's something we're observing, and it's pretty consistent. All right, so we're moving along here. So history taking, if pain limits walking. Now the next question is, show me where you hurt the most, right? And this kind of taps again into one of our papers we're going to look at. This is a case, and it's an unfortunately difficult radiograph to see, but this patient came in with what was thought to be a sort of a lumbar spinal stenosis picture. They ended up having more of a hip pathology. And so look at this. This is from a real case that Craig Brigham saw after the fact. So he was sent this patient by a colleague after they had a 4-level fusion. And look at this hip. Look at both hips, right? Like they're crap. The hips are terrible. But after this fusion, the patient was not better. Okay, it wasn't a spine problem. You don't want to mess that up. Okay. So disc herniation versus stenosis. These are some of the general descriptors for it. I'm happy to send some of the slides here to you guys so that you can take a look at it. But there's a difference. So generally speaking, the pathophysiology here is that discs dehydrate with aging, which we mentioned. Proteoglycan content decreases. There's a fibrotic effect that happens and a hardening of the disc that makes them less likely to herniate. That's probably not a bad thing. A lot of the quote regenerative medicine efforts have been trying to restore the youthfulness of our joints, but there may be some circumstances under which that is actually more harmful. Disc herniation may be one of them. We don't know. This is so much unknown right now, right? So one thing that should be interesting, and Craig Brigham was always good about pointing this out, is we talk about ligament and flavum hypertrophy with lumbar spinal stenosis, but that's an incorrect description. Ligaments generally don't hypertrophy, they become redundant. That is, as you lose height, they become excessive. So it's like if you have a belt and, say you have a 36-inch waist and you lose 6 inches, right? And then you try to use the same belt, it's going to be redundant. That's a similar phenomenon to what happens with the ligamentum flavum, okay? There's excess amount of it as we shrink, as we age. Synovial cysts are associated with the aging process. Some of that is due to excessive motion, which again is a reason that limiting motion may be beneficial for patients as they age. All right, just a general MRI here showing a young versus an older person, the older person having more desiccation. L5 is most commonly affected. Lateral recess at L4, L5 affects the transversing L5 nerve root. So we're going to look at the anatomy real quick here. I want you to know the difference there. You do need to be able to predict on imaging, even if you're a non-interventional person in the clinic. You want to be able to predict what kinds of problems a patient would have. Okay, so if we look at this, this is a normal myelogram, which is not usually done anymore. Sometimes it will be if a patient cannot have contrast studies. All right, so traversing versus exiting nerve root. Are you guys comfortable with this concept? Is this something that comes up? Maybe, maybe not.
Palmer doesn't teach me shit, Jim.
All right, dude. You're gonna be the world's greatest PhD spine doc, though, so. All right, so if we look at this, right? So here's the difference. If you have the exiting root, it's coming out right under here, under the pedicle. If you have a transversing, it's going across the disc. So if we're thinking about where the stenosis is occurring, it will affect which nerve root we're considering as is problematic. You have to align structure with the problem, right? Like the symptoms. And so it matters here in the sense that if you look at this myelogram example, right? Right here is where the exiting nerve root is coming out in the yellow. And here is where the traversing nerve root is coming out. So if you have a lateral disc herniation, let's say this is 4 on top and this is 5 on bottom. If you have a lateral disc herniation at L4, is it going to affect the exiting L4 or the traversing L5?
Traversing.
Exactly. You have to know that difference. So when you're trying to align structure with symptoms, you have to know what to predict. It really will matter. Okay. Are there any differences between these two images?
Yes.
Okay. So just grossly speaking, what's different on the left?
there's less contrast around that.
You guys see
disc.
my mouse? Do you see my mouse?
Yes.
Okay. Yeah. So right here, there's something happening, right? Like there's an interference of a certain type. So look how thick and linear everything is here, and pretty much everything is here, and then all of a sudden there's this gapping, right? So there's something that's occluding that structurally.
Jim,
again-
with that picture, sorry,
Yeah.
on that last slide, with that picture on the left, is that still a myelogram?
Yes.
Okay, thanks.
It's just inverted in terms of the color. So the white is black and the black is white. That's all. All right. So a couple of examples here just to align this myelogram with this axial image on the right, because that's something else that can really help you out. You know, you don't have to be an expert reading MRI or anything, but you do want to be able to align your expectations clinically with what's happening structurally. Because if there's a mismatch, then something else is going on, right? Because the reality is that some people will have structural changes and no symptoms. And some people will have symptoms and no structural changes. That doesn't mean there's no relationship between the two. That's the problem that we seem to be running into pretty frequently. Right? If I cut off your arm, most people are going to have pain, right? It's a noxious stimuli. We can do that experiment, by the way. Anyone who doesn't think there's any relationship between structure and experience can do that to themselves. Right. So it's not that because not 100% of the population experiences noxious stimuli the same way, that there's no relationship between the two. Like that's a false conclusion there. So when we're trying to build a case to understand what's going on in the spine, we at the minimum want to have a good story about what's going on structurally to meet the experience that a patient is having symptomatologically. Okay. So this is just trying to show where you're looking from a more sort of coronal view to the axial view here. Okay, the green arrow would be like what the surgeon would do surgically to enter that space. So like in a posterior approach, for example. All right, degenerative spondylolisthesis. I'm not going to touch too much on this, but you should know it's the most common at L4, L5. It affects the L4 nerve root, which is in this case exiting or transversing.
Exiting.
It's okay. Get a do-over. Transversing.
Transversing.
Yeah. Okay. Interestingly, more common in females. There is a genetic predisposition. There is a predisposition to symptomatology based on facet geometry. And it is associated with facet synovial cyst. And what is associated with facet synovial cyst in general? Does anyone know? Aberrant motion, so excessive motion at the facet over time chronically leads to synovial ballonment or cysts formation.
Jim, could you elaborate on excessive motion? That's what's creating the cyst?
Yes, essentially, that's correct.
And it's excessive motion just at that facet based off of like what is creating that excessive motion?
All sorts of things that we don't know.
Got it.
Yeah, I mean, it's more individually based, right? But if you do dynamic studies diagnostically, where you're looking at the motion that's happening at a particular facet that has a cyst formed, generally speaking, it will translate more on average than a person who doesn't have a cyst. Okay, it's just a thing that happens, right? Like a lot of people have facet cysts. For some people, it will be a source of a noxious stimuli. Okay. And this is what makes spine so hard, apparently, is the fact that it's not all or nothing. It's not 100% of the time. Some people will have cysts and never know it. Like we'll find it incidentally on imaging, right? But for other people, the cyst can be a source of noxious stimuli. It's not one or the other. And that's, for whatever reason, we have such difficulty with that. We have such trouble accepting the fact that some people experience a structural change differently than others. So Rainville is a master at this. And a lot of his work that they've done at New England Baptist Hospital that is sort of in the process of being published still, shows that there are different people who experience structural change differently. Some people are very insensate to it. Some people have all sorts of gnarly things happening in their spine and they like hardly are aware of it at all. And other people, every time the freaking, annulus breaks another ring, they feel it, right? But it's not our role to deny that level of discrepancy occurs, and it does. And that's just a hard problem for us. We suck at it. We're terrible. It makes musculoskeletal medicine all the more difficult. But it also makes it very interesting for people who want to tackle that as a problem. And so that's part of what I hope we kind of get across today. This is a degenerative spondy. Look at the space here on the left, right? And then the right side sort of shows the normal anatomical positioning there. Degenerative spondy is different than an isthmic spondy. You all familiar with the difference between those two things? All right, so if a cheerleader is 18 years old and she's been doing hyperflexion flips competitively for 7 years since her teenage years, and she develops axial back pain, what's the first thing you think might be wrong with her? Okay, so 18-year-old cheerleader going to college on scholarship, back pain bad enough that she needs to see a doctor for it or a clinician. What's the first thing that comes to mind?
It has to be a spondy, right?
Isthmic spondy.
Yeah.
That's the first thing that comes to mind because that is the most important diagnosis you can't miss. That's why. You don't sit there and say, oh, it's just a muscle spasm. Look, this is a highly competitive 18-year-old who's been doing this for 7 years, good enough to get scholarship. She doesn't walk into the doctor's office just for the hell of it. So we talk a lot about the psychosocial dynamics. That also matters in terms of what motivates people to see a clinician, right? And someone who's 18 years old is very different than someone who's 48 and hates their job. Someone who's 18 on a scholarship, just starting their career, is different than someone who's 48 and is a telemarketer and hates their job or works at Boeing in Seattle, like Michelle Bédier found out. That the number one predictor of work comp related low back pain disability in her population at Boeing, which Stan Bigos and her looked at in the 80s, had to do with workplace satisfaction. They hated their job. And I think what's so hard for us to reconcile is the fact that patients differ in terms of what changes the hierarchy of importance in the symptoms that they experience. It's really hard for us because we kind of want to have blanket statements that, oh, you're depressed, therefore your back pain's all related to your sort of psychosocial state. No, I mean, some people who have depression have bad fucking backs and they actually need surgery because they've got an abscess, right? You can't miss that. You can't just say that they're depressed. Like you have to be sophisticated enough in your evaluation of the problem that you can tease the difference between these populations out. That's what makes things really hard. Okay. All right, so we're wrapping up here. We're about to get into it. Case study. All right, so looking here, superior facet, inferior facet. When it comes to an isthmic spondy, look at the incidence. And in fact, this has been described as high as 8 or 9% of Americans. Okay, here is the problem, the pars interarticularis. That's where the stress fracture occurs. Isthmic spondies occur earlier in life. Interestingly, there was a great study out of West Virginia that looked at a coal mining population and followed 500 school children over the course of their lives and found that I think it was roughly for that population, 7 to 8% had isthmic spondies. Overwhelmingly, the majority of them had no symptoms whatsoever. So a lot of people who have an isthmic spondy are not going to experience symptoms. Some will. The majority of folks who have an isthmic spondy are going to have a unilateral pars fracture. Unilateral pars fracture can almost always be managed non-operatively. It will essentially, there will be fibrotic tissue that occurs across that pars fracture and it will just harden over time. They'll have some axial back pain intermittently, perhaps occasionally as they age, but there'll be no real issue or sequelae from that. The rare case that is important is the bilateral pars fracture, and that's a different beast entirely, and that's the one you can't miss. So for example, if a cheerleader comes in with axial back pain and after 6 months of you trying to manage it non-operatively, it is no better with rest or relative rest or exercise, modification, then what you want to do is you do want to image that person to make sure that they're not one of these who have a bilateral pars fracture. Because if you have a bilateral pars fracture, that's not going to fibrose down sufficiently to secure that aberrant motion, and they can develop neurological sequelae from that. So that's a difference.
Jim, I have a question.
Yeah.
It was my understanding that the pars fracture was a spondylolysis, and then the bilateral forward displacement was a spondylolisthesis. Is that completely wrong?
No, that's not wrong. There's a difference between translation and fracture. You're correct.
Got it. Okay.
Yep. Exactly. We hear about this rare thing called spondylolysis. You guys heard of that? Which is like basically when the thing falls off. It's like a grade 5 spondy, more than 100%. That rarely happens. That usually doesn't happen. So most people experience just small amounts of translation. You will see extreme cases if you work in spine long enough. But the reality is that the concern is really anchoring, right? So you can anchor unilaterally. If you have a unilateral pars that's intact, it will anchor appropriately, and you can manage that patient for the most part. A unilateral pars does not need aggressive intervention. You just want to modify activity, get them to be more familiar with their symptoms and how to calm it down. But if it's bilateral, that's a different scenario. Okay. All right. We're almost done here. Treatment. Explain the diagnosis. Reassure them based on the natural history, which we've sort of been discussing here. Describe coping methods. Activity modification, we just discussed. Avoid prolonged standing and walking. Again, this is kind of going back to lumbar spinal stenosis. Bicycle, swim, whatever they can do, allow them to do it and encourage that. If they're 70 years old and they need to go from doing marathons to biking 30 miles a day, bike the 30 miles a day. That's fine. No problem with that. Occasionally, you will have a use for medication intervention, such as NSAIDs. and they can help more with acute exacerbations of these symptoms. All right, indications for surgery. I'm not going to go into a whole lot of detail, but I do want you to be aware of the fact that these are what constitute a better outcome for surgery. So alterations of ADLs, not just pain. That's not the same. You can have pain and be doing everything you want to do in life, and that's a different patient than the one who can no longer go to the grocery store or take care of his wife or whatever, right? Leg pain needs to be worse than back pain, generally speaking. You want months of symptoms. They are refractory to all of our efforts for modification, okay? And you have to have an anatomic study that confirms that what is going on is likely a surgical problem, right? Because surgical problems are structural problems. That's what surgery does. Surgery can stop a soft tissue element, including a nerve, from being crushed by a bony element. They can decompress that space. They can go in there and open it up and create more room. That's what surgery does. Surgery does a few things very well. It debulks and it decompresses. That's what surgery does. And then you want to make sure, which we care a lot about here, that the comorbid condition does not preclude a satisfactory outcome. And with that, we're done with the PowerPoint. And I want to talk just a little bit about the 2 articles, okay? So firstly, Jim Rainville's article looking at the differences between hip OA and lumbar spinal stenosis. This is a very straightforward article. It's not something that needs a whole lot of deep diving, but I did want you to be aware of it. I know some of you have probably come across this article before, particularly Geronimo, from a guy named Justin Young. But this is a really nice article because it essentially looked at spine clinician beliefs about what kinds of predictors and physical exams differentiated hip osteoarthritis from lumbar spinal stenosis, and then it sort of assigned positive likelihood ratios, right, to each of those things. So what are some of your initial thoughts from this?
My thought was, I mean, we were taught, we had a lumbar module like a month ago, and it was like, if they have, if they're using the shopping cart for pain relief, it's automatically stenosis. And so that is very, it muddies things, that it's not that quick or easy to differentiate between these two things.
Yeah, exactly. I mean, this study was interesting because there are some things where you're like, oh, wow, that's what we're told, but not the case. Still, I think overall, there has been a decent consistency to some of what they found, right? So some of what they found does make sense. And so essentially all symptoms were reported by some patients with each diagnosis. That makes it hard. So if you're kind of like a part-time spine doctor or spine clinician, this is going to make this delineation more difficult for you between a hip and a spine. And remarkably, for reasons that are frustrating to all of us, we still see persons operated on for lumbar spinal stenosis when it's a hip problem, and we see people operated on for hip problems when it's a spinal stenosis problem. And that's not where you want to be. That's why this study is important, and studies like it. You have to be able to differentiate those two. One of the things that I think is pretty clear is that we probably have a lot more time to try to tease those out than we often give. So it's not like someone has a lot of pain in their hip or pain going down their leg and we need to immediately do something interventionally about it. I think that we need to take a pause and recognize that sometimes we're going to see symptom overlap, and we need to make sure that we're right when it comes to whether it's most likely coming from the back or coming from the hip. Yeah. So what kinds of things did made the most sense to you about this, about what they found?
Because you're differentiating, I think, mostly between lower extremity or separating like the pelvis and lumbar spine. I think that just made a lot of sense. Yeah.
Yeah. So you know, kind of specifically, so 8 symptoms were favoring hip OA, groin pain, which was the most important, and that's the one that, you know, typically we say is significant, right? Like, so groin pain, which is medial, really medial thigh pain. There's not a lot of good explanation as to why lumbar spinal stenosis, which typically occurs in the lower lumbar spine, would refer to the medial hip, right? Like, that doesn't anatomically make sense. So if you're having that symptom, it's probably more likely that it's coming from the hip after all, which is what they found. So that's good, because we say that a lot. And that one we happen to be more right about. Yeah. Knee pain, specifically knee pain, right? Pain that decreased with walking, that makes sense, because we usually will see the opposite with lumbar spinal stenosis, correct? That's why people with lumbar spinal stenosis do better with bikes and row machines. Flexion. It's very stupid in terms of what the nerve is doing. If you really go back to basics, and you think about how the spine in the upright position is different than when it's flexed, that does matter here. It matters a lot. Pain getting in and out of a car. So why would that matter? Would that affect someone with lumbar spinal stenosis, just thinking about it kind of in terms of structurally what's going on in the nerve? Not really. I mean, how long does it take someone, even the slowest person in the world, to get in and out of a car? Just envision the slowest person in the world. We're talking like 2 minutes, maybe. Not a whole lot of time to piss off a lumbar spinal nerve root, right? But the hip is going to be doing a lot of dynamic movement. The hip's going to be flexing in extreme ways. It's going to be changing position. It's going to have to extend. So that makes sense as well as to why that kind of maneuvering would be worse for a hip. Okay. And then how about the opposite? How about for lumbar spinal stenosis? So they found that pain below the knee, some pain in both legs, which we mentioned in the PowerPoint, could be one or the other. And why is that? Why do you think that is? Why would you have potentially pain in both sides with lumbar spinal stenosis? So if you go back to the etiology of lumbar spinal stenosis, it's age related. It tends to be fairly symmetric, right? That's why. Like, don't overthink it. It's pretty symmetric. It's a genetically influenced, age-related phenomenon that happens. Is left and right going to be that much different in the average person? So their back's going to look fairly symmetric in most cases, on average. And then finally, the big one. What's the major difference between, according to this work, lumbar spinal stenosis and hip OA? Like, if you had to just say one thing that's most different.
Was it walking with a limp?
So in this case, I would say it's the neurological exam finding, right? With a hip OA, you're not going to have neurological deficit, right? So they saw that with those who had the lumbar spinal stenosis, they were more likely to have an actual neurological deficit of some type, which makes sense because, again, with lumbar spinal stenosis, you're crushing a nerve root. That's literally what it is. Okay, you're compromising it. With hip OA, it's not. It's a referred pain. It's a type of referred pain.
Jim, I kind of had a question. When we were talking about pain in like bilateral legs, and I was thinking about like OA, is it an incorrect assumption to assume that that would be affecting both hips?
Well, from the general age-related standpoint, it does tend to affect both hips on average too. So that's correct. Hips are a bit more forgiving in terms of the pain experience than nerve roots. Nerve roots are pretty sensitive, right? So like anyone who's had an acute disc herniation or radiculopathy or anything like that, they describe it as one of the most painful experiences they have. We have lots of patients who describe it as more painful than childbirth. No one ever says their hip OA is more painful than childbirth. So the nature of the noxious stimuli is different. And so the ability to accommodate the slow degradation of the hip joint is generally speaking better for people, right? And so the other thing is that with a hip, you do sometimes see unilaterality with how someone is handed. So like their handedness. Okay. So being right-handed versus left-handed sometimes does affect the predominance of the symptoms that they have with hip degeneration. It's not uncommon though for us to see patients operated on bilaterally over time because of what you're pointing out, which is that, yeah, I mean, in terms of the age-related phenomenon, they do both change at a similar rate.
Yeah, that helps. Awesome, thanks.
Yeah, but I think the most important point there is the fact that lumbar spinal stenosis is a bit less forgiving because of the nature of the neural compromise that's taking place. Which is also why like the whole concept of femoral acetabular impingement is being challenged right now in younger people, right? Lots of us have cam deformities and structural changes in terms of the acetabulum and the femoral head, and the assumption that if there's asymmetry there, it will predict pain is probably not a good one, because we don't have a clear, obvious neurologic compromise that's taking place in the hip like we do in the spine.
I have a question. I was wondering, so I assume like spinal stenosis, mostly we talk about it in lumbar spine, but like if it appears in the cervical spine, do you see the same commonalities, symptoms, and certain pathologies when it's in the cervical versus the shoulder compared to like the lumbar spine and the hip? Do you get what I'm asking? I don't know if I asked that in a great way.
Yeah, I mean, so just right off the bat, the cervical spine, we care more about myelopathy, right? The lumbar spine, because of where degeneration tends to occur, is not an upper motor neuron problem for most people. And in the spine, we don't have the same, you know, amazing to use this word, but biomechanics as we do in the lower spine, right? Like the lumbar spine, which carries more weight, has different dynamics of offloading and onloading than in the cervical spine. So the cervical spine, we care a lot more about myelopathic changes. The diameter of the canal is different, right? It's fairly forgiving in the cervical spine for most people. You know, you can have a radiculopathy, but generally speaking, for radiculopathies, we accommodate pretty well over time. And so I do think that the loading of the lumbar spine and some of the changes that occur in the geometry affect it differently than the cervical spine. Yeah. Most people will have radiculopathies in the upper extremities that adjust pretty well to time. Yeah.
That makes a lot of sense. Thank you.
Yeah. It still happens, of course. And if they do have myelopathic changes, that's like a whole different beast, and that's a different discussion. And it's very important not to mess that.
Jim, I have a question.
Yeah.
With someone who does have like symptomatic lumbar spinal stenosis, and you're seeing them as like a clinician or as a PT or chiro, how would you suggest going about explaining this kind of structural thing without making it feel like they can't change their, like, that they feel helpless with it?
Good question. So I think that the thing you have to do is you have to explain structure is it provides boundaries through which function can occur, right? So if you have structural change, that's not saying that you can't find ways to adapt functionally. It's saying that we may have to change some of the things we do now compared to how we used to do them, right? But that's not the same as saying you can't do something. You just have to adjust to it. You have to find ways that you can still carry out your same goals functionally within perhaps some changed boundaries structurally. So the reality here is that, you know, we want to be prepared for the folks who have significant limitations or need and not miss problems that can go bad quickly for them, right? But at the same time, still the majority of people exist in a more flexible domain that do accommodate well and that just need our guidance to help them find out what that is. Okay. So a good example is glasses. Okay. I got to med school, never needed glasses. Got into med school, all of a sudden my vision started doing this. I needed glasses. Okay. I found a quick and easy way to accommodate to that structural change that was taking place in my eye. The same is true for, thanks, Geronimo. The same is true for a lot of the structural changes that happen in our musculoskeletal system. So you know, I'm not gonna go play lacrosse anymore at my age, but I don't need to, right? Like now I'm a doctor. I take care of patients. I do things differently, so I adjust to that. I played lacrosse in high school. You know, every damn day we'd go out there and train for 3 hours and just beat the crap out of each other. And like, I don't do that anymore. I would hurt like hell every day if I did that now. That's fine. I don't need to. Like, I changed. I adjusted to it. I do things differently. I assign different value to what I do every day. It's the same way with people as we change structurally. We want to make sure that we just accommodate and try to maximize the threshold of our existence that we can within things as they change. right? Sometimes that means that people perhaps are being told by their family or communities or other doctors that they can't be doing something when they can. And so your job is to push them back up, right? And to try to expand it again and to say that, yeah, I understand. Yeah, you're 50 years old now, but you can still go prepare for that marathon, right? And so there's this balancing act with trying to find out what our function can accommodate during this aging process, but no one knows what those limits are, right? We don't have a book that can predict it. All we can do is we can work with the person in front of us and say, all right, so you've got some hip pain, you can do 90 degrees of flexion. That's not the 120 you used to do 20 years ago, but with 90 degrees of flexion, you can still run. So we can get you back to doing those things or whatever.
What about you keep referencing like a stationary bike or a rower?
Mm-hmm.
Is it even worth trying to get back to more upright activities or more upright exercises and like progressively, see if they can tolerate it? Or are you just like hammering the things that they can just based off flexion?
Yeah, I mean, so we know pretty well with lumbar spinal stenosis that people just don't tolerate upright positions well. That's just the nature of the beast. You can push it and see what they can do, but I think that the reality is we understand quite well at this point that most folks with lumbar spinal stenosis don't tolerate certain positioning well. Is it and they don't necessarily accommodate to that. So it's not, we have no evidence whatsoever that you can take someone with lumbar spinal stenosis and get them to tolerate upright posture, right? Like that's just not a thing. That doesn't exist. No one has shown that. So I think we need to appreciate that fact. And the option is we decompress them and we try it, or we don't go that invasive route and we say, you know what, if you're more comfortable biking now, let's bike. In a population health perspective, it would be futile and expensive and disastrous if we said that everyone who can't stand up perfectly should be cut, right? Like that would not work out, because unfortunately, every time you do those interventions, even if they can help the structural problem, that doesn't account for the many different types of complications that arise, the cost, right? The loss of time with your family, the loss of time at work, or whatever the case is. Like there's all of these other variables that go into it. We can't tease those out. So it's not a good population health strategy to decompress those people. So probably what's much better is to say most people will accommodate really well and can adjust their activities and still stay healthy and active and find things that they enjoy doing in life. And still they can walk for 15 minutes upright without having a problem. And you know what, when you're 75 years old, how much walking do you need to do more than 15 minutes at a time without resting? So you know what, sit down on the damn stool, rest for 5 minutes, get up and go again. I mean, there you go. You've got 35 minutes worth of upright activity you can do. So thinking like that is probably a much better population health strategy than trying to address everyone structurally. Yeah. But I think it's pretty clear that it's not like we can get people's, nerve roots are pretty uncompromising. Like they don't adjust well to positions that they don't like. They're very stubborn. It's like poking your eyeball. It's the same kind of concept. Doesn't take much. You do that for 30 seconds, it's going to start turning red and hurt really bad and get inflamed. That's exactly what happens with the nerve root. It's the same kind of thing. Hopefully that was helpful. The other study, we didn't get into it much, but I just wanted everyone to take a look at it because what's important there to me is the fact that there are reasons that older adults, and in this case, persons with lumbar spinal stenosis, may not even come to receive care when they otherwise would or want to. There are psychosocial reasons as to why people don't seek out care that they otherwise might want or need. And that's really important to consider. Dr. Macris has done a few studies on this topic. I would PubMed her. And Jana Friedley also, who's kind of a protege of Rick Dio. They all do really great work in this space, and you might want to be familiar with them. Sound good?
Sounds great. Does anyone have any final questions?
I do have one question, actually. I'm not sure if I can elucidate my thoughts as well as I want to, but as far as a non-adapting nerve root, I know that there's some cases where you can have somebody with, say, foot drop with obvious motor and sensory deficits, and yet as long as it's not progressive, that can reverse and they can regain function of that foot. Is there that case in spinal stenosis or cord compression, or are those two entirely different instances?
Yeah, that's a good question. So the degree of damage to a nerve determines whether it can recover or not. And so, depending on the degree of damage to an axon, that is what drives recovery potential. It's not some random process. We know it pretty well. And the electrodiagnosis community studies this in very exquisite detail. And this is where like EMGs come in handy, for example. So you can evaluate the degree of nerve damage and predict over time whether or not that nerve is regenerating, right? So it's hard clinically to know how badly damaged a nerve is, and that's the problem that we face. Is we don't have readily available information during a physical exam and history to determine to what degree a nerve has been damaged. You can use an electrodiagnosis study to monitor recovery and predict whether or not there's sufficient neural integrity for that to regenerate. And if a nerve is sufficiently intact, it will regenerate. On average, a nerve can regenerate about 1 millimeter a day. So if you're talking about a foot drop, it's a long process of recovery, but it can recover. But that's what we're seeing. We're not seeing some random process where we're confined to the degree of the damage itself. And that's what drives it. It's pretty predictable. So it's important that we appreciate the fact that the reason a foot drop might recover is because the nerve was still intact. Right, so you can have demyelination, for example, and that's very different than having a complete transection of a nerve. If a nerve is completely transected, it will die, and that's a fact. There's no pseudoscience to that. So when we see a recovery, it's because the nerve was not completely transected, and it's that simple, right? For lumbar spinal stenosis, generally speaking, we're not talking about transections or anything like that. Lumbar spinal stenosis is primarily a functional problem. It's an interference of a person's ability to function. Most people do not experience lumbar spinal stenosis to the degree that they are like destroying their nerves, right? That's not the problem we're having. We're having one of function, we're having one of interference with their ability to go about their ADLs and stuff like that. So that would be the difference. Yeah.
Is isn't it a nerve issue that's causing that functional limitation though? I mean, I guess you said it wasn't necessarily pain that everyone with lumbar stenosis complains of, more of a like a functional and structural limitation, but what is, I assume it was the compression of the spinal cord or the roots that was kind of the cause of that.
Yeah, I mean, so most people with lumbar spinal stenosis, the reason that they lose their normal functional capacity is due to pain or noxious stimuli, right? These are not people who lose control of their left leg or randomly have problems, generally speaking, when it comes to nerve loss. These are people who have a sort of predictable, slow degradation of the comfort through which they can continue ambulating the way they used to or participating in activities the way they are because of a noxious stimuli. That's very simply put a structural compromise of the nerves required for them to be functional. So it's different than someone who has, like I call it, Aquinas syndrome, right? Or someone who has a massive tumor that knocks out their nerve root, or someone who has a traumatic laceration of some sort, right? Like this is why lumbar spinal stenosis is a degenerative problem. It's not an acute problem for patients. Okay, so there's a difference between losing nerve function and noxious stimuli that affects our function. And so I think it's important for us to sort of appreciate that difference.
Is there any evidence that early non-surgical management is beneficial, or even like, you know, what really value are we providing besides putting them in, maybe that's not the right way to put it, but like if it is truly just finding what they can tolerate from a, you know, a modification of activity and exercise, what does it look like for us with those patients? Is it just providing that and then, you know, moving them forward, or really is there like, you know, a certain time period we should be seeing them with, or just referring to trainers? What are your thoughts there?
In general, I think that the most important value we provide is helping people accommodate this process. I think that most people can accommodate this process. We have a lot of unfortunate social beliefs that go against the notion that people can accommodate without some kind of intervention. We provide that role by showing them that they can. I think, though, that we also are part of the adjustment process itself by helping them find ways to cope. Right? Yeah.
Dope.
Yeah, I mean, it's always a spectrum of disease presentation, right? Most people are going to fall in the middle. You're going to have some people who look terrible on diagnostic imaging, but are like running around doing all the things in life they want to do because they have great genetics and they don't have, you know, facet hypertrophy, and they don't have some of these other things going on that, you know, may make them a little more susceptible like the rest of us. And then you're going to have people on the opposite end of the spectrum that that have such debilitating pain with it that they do end up, you know, needing some kind of structural address. But the reason that lumbar spinal stenosis boot camps of all varieties, you know, Jim Rainville's been doing it since the 1992, started it in Boston with Lisa Childs, who's a CBT trained PT and brilliant. The reason that they can help most people is because most people can accommodate to lifestyle adjustments. And if we simply provide more patients with the opportunity to experience and undergo lifestyle change, then they will have the ability to experience that kind of outcome that comes from making those changes. And I think that's part of the deficit in our health system, is that not enough of us are just simply out there pushing the appropriateness of these kinds of changes and modifications to happen for these patients. So more of us need to be doing it. Yeah. Most people will adjust well. Most people will not need surgery, and we can help most people, and that's what matters.
Hell yeah. Thanks, Jim.
You're welcome.
It's great. Awesome. Well, yeah, I appreciate you taking time out of your Saturday morning, and everyone else, thank you so much. All right.
Good to be here, and everyone have a great day. Okay.
Yeah. Thank you. All right. Bye.